Recording has also started.
On behalf of AP Society of Nephrology, good evening all. We welcome you all to the eye-kidney conundrum. We commonly face the eye-kidney problems, especially our CKD patients are suffering from diabetes, and we have clinical dilemma whether it is diabetic kidney disease or non-diabetic kidney disease. For that, we always approach our ophthalmologic colleague, and they will give us lot of clues regarding diabetic kidney disease or non-diabetic kidney disease, and depending on their word only, we'll plan biopsy for our diabetic patients to know the diagnosis of CKD. Not only in diabetes, in pediatric CKD, our ophthalmic colleagues give lots and lots of information for our kidneys, as we can't see the kidneys, but we can see the eyes, and these eyes are retina, all from cornea. We can get so many clues. And for this eye kidney conundrum, I request our Professor Bharani Kumar sir to start the presentation. Before that, I request my colleague Varun to introduce the chairpersons and speaker.
Thank you, ma'am. So first, it gives me immense pleasure to be a part of this, and even more pleasure to be able to introduce Shivkumar sir, who has been a legend we have been admiring from the time. Now I was working in Chennai, and with person who has more interest in PD. We have heard so much about Shivkumar sir. We are about his passion, and he's a legend for all of us. So it does not need an introduction for a nephrology community. But he's currently working as a professor in SWIMS Tirupati in Department of Nephrology. He has had many international present awards to his name from Japanese Society, from Sandeepan Rishi Gnanpita Sannman, Vidya Acharya from the Indian Society of Nephrology. The government of Andhra Pradesh presented him with the Best Teacher Award in 2017. He has many accolades to his name. He was a former dean of SWIMS University and the former president of Indian Society of Nephrology Southern Chapter and Indian Society of Peritoneal Dialysis, and he has more than about 115 publications to his name. So I welcome you, sir. It gives me immense pleasure to welcome you for this webinar, sir.
Thank you.
Then I also like to introduce Dr. Chandramohan, sir. He's a senior ophthalmologist from Vijayawada, from where I practice. He's a vitreoretinal consultant working in Modern Retina Center, Vijayawada. So he completed his MBBS from SV Medical College, Tirupati, followed by which he did his MD ophthalmology from Aravind Eye Hospital, Madurai. After his MD degree, he did his fellowship in VR, vitreoretinal surgery, from again Aravind Hospital, Madurai. He is very active clinical in practical works, and he has more than 10 publications to his name, and also authored a few chapters in textbooks. Welcome, Chandramohan sir, for this webinar. And I would also like to welcome Dr. Anil Kumar sir, who is also chief consultant with Modern Eye Hospital Research Center in Kurnool. He completed his MBBS from JJMC Davangere in Karnataka, followed by which he did his DNB ophthalmology from Aravind Hospital, Madurai. Then after his post-graduation, again he did fellowships in pediatric ophthalmology and strabismus. So he has very active pediatric ophthalmology practice, and is also a fellow of the International Committee of Ophthalmology. It's a pleasure having you on board the chairperson, Mr. Welcome, sir. Welcome to the webinar, sir. So coming to
introduce the speaker.
Yes, coming to the topic per se, today we'll be talking about the eye kidney conundrum. We'll be whether Dr. Bharani Kumar sir will be telling about his ophthalmologist perspective of the different eye environments in retinal diseases. Bharani sir, he was a retired professor of ophthalmology from KMC Kurnool, where he worked for almost 32 years. And now he is currently working as a professor of ophthalmology in Vishwabharati Medical College, Kurnool. He also completed his SV Medical College from SV Medical College Tirupati, MBBS, in 1981. Then he went on to do his MD ophthalmology from the prestigious All India Institute in New Delhi, which he completed in 1984. So Sai has a very good track record when it comes to academics, and he was a very active. His active work is known to many people in the field of ophthalmology. I welcome you, sir, for the webinar, and I hand over to you for the presentation, sir.
Can I start, madam?
Yes, sir.
Yes, sir. Yes, sir.
Good evening to all of you. First of all, I am very much thankful to the AP Nephrologists Association President, Secretary, as well as the President and Secretary of local IMA Kurnool branch, and also the President and Secretary of Kurnool Ophthalmic Association for giving me an opportunity to present this particular topic today in the today webinar. The basic stimulus for taking up this project is the last month webinar, that is the cardio-renal syndromes. Most of you are aware of the associations in a very scattered way. That means in a particular glomerular nephritis disease, AMD will be there. It will be very scattered way. My basic idea is to put all the things under one heading so that it will be very much useful for general medicine PGs and to some extent for DM nephrology students also, and also to the ophthalmic PGs, as well as to the practicing nephrologists and physicians and also to the ophthalmologists. And I am very much thankful to Dr. Saivani for allotting this particular topic to me. See, the topic today is the eye-kidney relationship, or otherwise called as eye-kidney conundrum. Basically, the conundrum basically means a riddle. The ideal title for this is, the other meaning for it is oculorenal relationship, the title which I have included for this particular topic. So coming to the relationship, both these two important organs, one in head, whose purpose is vision, the importance of which we all know about it. The other one in the abdomen, whose purpose is basically to remove the waste products from the blood, failure for which leads to accumulation and which will lead to the serious consequences like a cardiac kidney failure, etc. Luckily, both are two in number. And is there any relation? Yes. Let us see in the further slides. All of you, the physicians and nephrologists, are aware of this great personality, that is Richard Bright, who reported an association between blindness and renal disease way back in 1836 itself. The eye and kidney and share a developmental, structural, physiological, as well as pathological pathways. Most important is the development of retina and kidneys occur at the same embryonic stage, that is the 4th to 6th week of gestation. Probably any insult during this particular period is probably responsible for the so-called oculorenal syndromes, which we will subsequently talk in the later slides. Let us see if there is a gross similarity in the relationship of outflow systems of lacrimal outflow system as well as the urinary outflow system. For example, if we take two kidneys together, the lacrimal canaliculi is almost equal to ureters. The lacrimal sac is almost equal to bladder, and the nasolacrimal duct is almost equivalent to urethra. For example, if there is an obstruction at the lower level of nasolacrimal duct, probably it leads to accumulation of the tears in the lacrimal sac. And with the secondary infection of it leads to dacryocystitis and its ensuing problems. Similarly, an obstruction at the lower end of the urinary system can lead to retention of urine and also the subsequent infection, either antegrade or retrograde also. And the obstruction at the any level, even at the ureter level, can lead to hydronephrosis and also its consequent problems. See, the ocular and renal systems are targets of end organ damage in various pathologies. This damage can occur simultaneously or some specific renal conditions leading to ocular changes, or rarely vice versa. So the retinal microvascular changes are predictive of CKD, and the CKD patients are more prone for ARND, diabetic retinopathy, as well as glaucoma. Coming to the details of the anatomical and physiological relationship, both glomerulus and choroid have extensive vascular network of similar structure. Inner retina and glomerular filtration barriers share the similar developmental pathways. Renin angiotensin aldosterone, that is RAS, is found in both kidneys and also in various ocular tissue, whose purpose is to regulate the blood volume and also the systemic vascular resistance. The arrangement of retinal pigment epithelium and Brooks membrane and choroidal capillary endothelium almost resembles the glomerular endothelium and the glomerular basement membrane and podocyte. That is, glomerular endothelium is almost equivalent to pigment epithelium. Glomerular basement membrane almost have a similar structure of Brooks membrane, and podocyte is almost performs the functions of the choriocapillaries. This is the gross picture showing the relation of retinal pigment epithelium versus the glomerular endothelium and the Brooks membrane almost related to the basement membrane of the glomerulus, and the choriocapillaris is almost related to podocytes. This is the finer details showing the same choriocapillaris related to the podocyte, and the Brooks membrane always to the glomerular basement membrane, and the RPE cells almost related to the glomerular endothelium. This is how the photoreceptor end products reach the choriocapillaris. This particular photo shows. The renal and circulation, a word about the renal and retinal circulation develops by angiogenesis to supply the inner 2/3 of the retina. Peritubular capillaries, they supply the vasa recta in kidney. They populate the media and inner cortex. And the Bowman's capsule, all of you know that it encloses a cluster of capillaries, the glomerulus. Blood enters via the arteriole and leaves via the afferent arteriole. This is the articular vascular supply of the kidney as well as that of the retina. In the retina, the supply to the retina is through the minor arterioles, and it leaves the retina via the minor venules and then into the systemic circulation. Regarding the fenestrations, choriocapillaris endothelium has fenestrations of about 8 to 18 nanometers, which allows fluid exchange in the subretinal space. Similarly, the glomerular endothelium has the similar size fenestration, almost about 17 nanometers, which facilitates ultrafiltration into the Bowman space. So this is the photograph showing the fenestrations in the choriocapillaris as well as in the Bowman's membrane. Coming to the pathological associations, glomerular basement membrane and Brooks membrane contain alpha 3, 4, and 5, and also type 4 collagen chains. Diseases involving type 4 collagen can affect both kidneys, eyes, and as well as kidneys, resulting in nephropathy and retinopathy simultaneously. The example being as seen in Alport syndrome. In anti-GBM disease, IgG antibodies develop against the alpha-3 chains deposited on the glomerular basement membrane, which leads to glomerular nephritis. Whereas similarly, the IgG deposition on Brooks membrane, it results in the development of choroidal ischemia and also the retinal detachment. In membranoparathrotic glomerular nephritis, type 2 electron-dense deposits are deposited on the glomerular basement membrane. The same deposits are deposited on the Brooks membrane also, leading to age-related macular degeneration. This suggests an immune regulation link between the eyes and kidneys. This association especially suggests. These are the depositions in membranoparathrotic nephrosis as well as the depositions in the eye, that is over the Brooks membrane. The word about the RAS system. RAS is wide, apart from kidney, RAS is also widely expressed in retinal and choroidal vasculature also. Angiotensin II acts via the type 2 receptors, leading to chorioretinal vasoconstriction. And excessive activation of RAS leads to a diabetic retinopathy in diabetic patients and also the CKD in other patients. Endothelin 1 in eyes basically mediates vasoconstriction via the endothelin receptors present in choroid and retinal vascular smooth muscles. In kidneys, whereas in kidneys, these endothelin A receptors are present in vascular smooth muscles of glomeruli and also the vasa recta. A selective blockade of these endothelin A receptors, like a drug like bosentan, it has very different functions in eyes as well as kidneys. In eyes, it increases the retinal blood flow and thereby it reduces the pericyte apoptosis and retinal thinning also. Whereas in kidneys, it causes the intraglomerular hypertension, podocytopathy, and fibrosis, leading to progression of CKD. Coming to the risk factors, common risk factors between the eyes and CKD are: number one is old age, the second one is smoking, hypertension, diabetes, obesity, and hyperlipidemia. This is the flow chart showing all these risk factors. The top one is the mutations in genes can affect both these organs, like cardiometabolic factors, oxidative stress. Basically, there is a microvascular dysfunction and also the atherosclerosis. This is another flowchart shown how these risk factors, through these mechanisms, they affect the kidneys as well as eyes, that is the renal angiotensin system, advanced glycation in products, genetic polymorphosis, accelerated atherosclerosis, vascular remodeling, endothelial dysfunction, as well as oxidative stress. All these mechanisms are going to affect these two organs, resulting in various diseases. As I explained, localized RAS is also found in retina, especially in microvasculature, Muller cells, and also in ganglion cells. In diabetic retinopathy and retinopathy of prematurity in children, which are both vasoproliferative vascular disorders, elevated levels of pronin, renin, and angiotensin has been reported. Especially RAS blockade may benefit in retinopathy in these situations. RAS has a role in even glaucoma also through the vasoconstriction. It reduces the aqueous secretion. And regarding the advanced glycation end products, these are the result of oxidative stress. They convert the soluble lens proteins into insoluble lens proteins, thereby leading to lens yellowing in earlier stages and accumulation of age in later stages, leading to the total development of cataract. In diabetic retinopathy, the toxic effects of age target the retinal pericytes and induce retinopathy. This is a photograph showing how the damage occurs in diabetic retinopathy. For example, an occlusion occurred at the arterial end of the arterial end, leading to occlusion as a result of base membrane thickening, endothelial cell damage, and also the RBC changes, and platelets thickness also is increased. This result in ultimate development of aneurysms in the capillary end, and once the capillary is ruptured, they lead to hemorrhages. This photograph showing how the loss of pericytes, they induce the process of so-called retinopathy. Regarding the genetic polymorphisms, mutation in the complement factor H gene, basically it leads to membranoproliferative nephritis, hemolytic uremic syndrome, and the ocular association is ARMD. Regarding the accelerated atherosclerosis, atherosclerosis is accelerated in chronic kidney disease due to following reasons. One is increased serum lipoprotein, homocysteine levels, decreased transforming growth factor P1 levels, decreased glomerular filtration of free radicals, generating nitrogenous waste products. All these are responsible for the acceleration of atherosclerosis in CKD. As sclera and Brooks membrane share the same collagen and elastin like median and large size arteries, deposition of lipids on sclera and Brooks membrane, it leads to exudative ARMD. Regarding this is the photograph showing how the elastin and collagen have the similarity in the Brooks membrane as well as the medium-sized arteries. This is a photograph showing the wet ARMD in the early stages and in the advanced stages. Erythropoietin is a very important substance which is produced by the kidney. Especially in the kidney diseases, the quantity or the erythropoietin is decreased. So decreased EPO. In the CKD cases, it leads to ganglion cell damage. In glaucoma cases, due to decreased neuroprotective mechanisms. Another substance is a cystatin C, which is found in all tissues. Basically, it's a marker CKD. It has a basically from ophthalmic point of view, these cathepsins are involved in the photoreceptor phagocytosis and also the suppression of this vascular endothelial growth factors. Especially this cystatin C, it inhibits these actions. So thereby leading to ARM as well as the progression of diabetic retinopathy in diabetic cases. Regarding the anterior segment manifestations in eye, the secondary hyperparathyroidism due to the renal failure, it leads to hypercalcemia and deposition of calcium in lid margins and conjunctiva and cornea. In cornea especially, it leads to band-shaped keratopathy. And one important point is these patients, especially who are undergoing hemodialysis, usually they develop dry eyes due to increased tear secretion. This is a photograph showing the band-shaped keratopathy. And these are the calcium deposits on the lid margins. And the cataracts also is aggravated in cases of CKD cases, especially it is the increased serum cystatin C, it leads to cortical cataracts, and increased blood urea, nitrogen, and creatinine, they especially lead to the development of posterior subcapsular cataract, and especially when the patient is an immature cataract stage, if he is undergoing hemodialysis, in some situations there is a rapid progression of this cataract to an advanced cataract, that is a mature cataract. This is a photograph showing lens yellowing and the sudden conversion of this immature cataract to mature cataract due to the osmotic mechanism when the patients are undergoing hemodialysis. Regarding the intraocular pressure in CKD cases, the intraocular pressure increases as a result of osmotic pressure created by increased urea concentration in aqueous, which leads to fluid overload, thereby raising the IOP. In dialysis disequilibrium syndrome, as a result of removal of urine toxins and other solutes from vascular compartment, urea gradient is created, leading to fluid movement into the anterior chamber, raising IOP. So if patients undergoing hemodialysis as well as CKD patients, the incidence of glaucoma is very high. So CKD patients, whenever they come to ophthalmologists, especially these patients, they definitely tell us that we are kidney patients in the beginning itself. So especially if this patient says that they are CKD patients, better ophthalmologists always check their intraocular pressure because of these two mechanisms. Regarding the posterior segment manifestations, arterial hypertension leads to high volume velocity of blood flow, leads to damage of small caribal vessels. And especially few studies have shown retinal vascular narrowing was associated with CKD when the estimated glomerular filtration rate is less than 45 ml per minute. Regarding the hypertension, arterial narrowing leads to ischemic changes like cotton wool spots and flame-shaped hemorrhages, hard exudates, and retinal edema. Optic disc edema can occur in very severe cases, not in all earlier cases. These patients, they have a high chances of developing central retinal artery occlusion as well as central retinal vein occlusions. Both will lead to severe visual loss. These are the photographs showing the hypertensive retinopathy, especially when the CKD is associated. This is the fundus picture, especially in renal hypertension. Continuing with the posterior segment complications, deposition of lipids in sclera, it leads to results in elevated coronary capillaries pressure, leading to exudate retinal detachment in some cases. And the uremic optic neuropathy also is another problem that can occur in the CKD patients, especially when the urea levels are very high. It is reversible if timely managed by hemodialysis. These are the pictures of rheumatosynous retinal detachment, and this is the so-called exudative retinal detachment, which is very common in CKD patients. Regarding diabetes and eye and kidney disease, diabetes affects both the renal and vascular systems of both organs. There is a bidirectional relationship between diabetic retinopathy and CKD. It is the microvascular changes. They form the common pathological pathway for manifestations in both kidneys as well as in eyes. This retinopathy, once retinopathy occurs, there is an increased chances for developing the chronic retinal disease. So in diabetes retinopathy, the vascular abnormalities manifest as microaneurysms, dot and blot hemorrhages, and venous bleeding and heart exudates. Whereas ischemic changes, they manifest as substrate base and neovascular disc retina. And one important finding is that increased retinal exudates were seen in fundus when CKD and diabetic retinopathy coexist. So this is a normal diabetic retinopathy, how it progresses in various stages from beginning to advanced stages. See, in a normal diabetic retinopathy without CKD, especially the fundus picture will be like this, especially corresponding to this one. Whereas when the diabetic retinopathy is associated along with CKD, this is the fundus picture. That means there is an increased amount of exudation. That is a very characteristics of when diabetic retinopathy is associated with CKD, especially due to the choriocapillaries, they will become very weak. Permeability will be increased, thereby leading to increased lipid exudation. Coming to the ocular changes in hemodialysis, especially most of these patients undergo hemodialysis. Certain ocular problems do occur when the patients are undergoing hemodialysis. This is in the dialysis equilibrium syndrome. With the hemodialysis, it lowers the serum osmolarity more than ocular osmolarity, thereby creating an urea gradient generated between the aqueous humor and blood owing to the blood aqueous barrier, leading to water movement into the anterior chamber, raising IOP. This is one thing, so the glaucoma can occur. And these hypotensive and anemic episodes in hemodialysis sometimes rarely leads to anterior ischemic retinopathy, which leads to gross visual loss. This we have to, especially nephrologists have to remember. If the patient complains of sudden loss of vision, this may be one of the causes. And patients undergoing hemodialysis also, especially exudative retinal detachment can be seen rarely, especially in end-stage renal disease on hemodialysis. The reason is the increased choriocapillaries permeability. And the other posterior segment complications include deposition of lipids and sclera results in elevated choriocapillaries pressure, leading to exudative retinal detachment. And sometimes the ileunic optic retinopathy also reversible if it is timely managed. This is the exudative retinal detachment picture. This is the summary of common pathogenic mechanisms handling both kidney and eye diseases. If the mechanism of CKD is due to RAS dysfunction, the ocular associations are diabetic retinopathy, glaucoma, and retinal vascular damage. If the inflammation is the mechanism of CKD, then the result ocular association include age-related macular degeneration, diabetic retinopathy, and retinal vascular damage. If the genetic polymorphisms is responsible for the CKD, then association is ARND. If a decrease in clothoprotein, especially which happens in renal diseases, if it is responsible for CKD, the ocular associations include age-related macular degeneration, cataract, and retinopathy. If endothelial dysfunction is responsible for it, the ocular associations are age-related macular degeneration and cataract. If atherosclerosis is responsible for the CKD, then cataract, age-related macular degeneration, diabetic retinopathy, glaucoma, and retinal vascular damage can occur. If the oxidative stress is responsible for the CKD, then the ocular associations are again ARND, diabetic retinopathy, cataract, glaucoma, and also the retinal vascular damage. Some of these are the various, there are many systemic diseases commonly affect kidneys as well as this is shortly, there's a big list is there because of the paucity of time I have included only some topics. So diabetics affects both organs, hypertension affects, HIV affects, SLE, collagen disease, even the tuberculosis also affects both these organs. Coming to the congenital anomalies affecting the eyes and kidneys. So the basic reason is the retinal and renal organogenesis occurs between the 4th and 6th week of gestation. It shares usually several genes, including BMP7, PAX2 gene, and WT1 gene also. Mutations in these genes results in various ocular renal syndrome. One example is the Weger syndrome, whose components all of you are aware of it: Wilms tumor, aniridia, genitourinary anomalies, and also the mental retardation. Von Hippel-Lindau disease, which is characterized by cerebellar and retinal hemangioblastomas, renal stoma, and also pheochromocytoma. Tuberous sclerosis, which is very characteristic of angiolopomas affecting the brain, skin, kidneys, eyes, and also heart. The Albert syndrome, The ocular component being the lenticonus. These patients suffer from sensory neural hearing loss, nephritis, and Bardet-Biedl syndrome, which is a very, among all these, this is the one condition which is very common and which is characterized by obesity, polydactyly, and the renal associations are also there. Some systemic drugs do affect the kidneys as well as ocular infections. One ocular drug, the Dimax, it leads to development of renal stones especially. And the many big list is there which affect both kidneys as well as the eyes. Coming to conclusion, basically, the retinal microvascular changes are predictive of chronic kidney disease. CKD patients are more prone for ARND, glaucoma, and diabetics are more prone for early diabetic retinopathy. So, especially young patients with renal impairment, nephrologists have to search for ocular findings, may be helpful to fit the case into one of the oculorenal syndromes. The main importance is recognition of overlapping pathophysiology between the renal and ocular diseases, helps in prompt diagnosis, and timely referral may help patients for timely treatment to prevent the so-called complications in both organs. And recognizing and understanding links may lead to the development of new diagnostic and management strategies for both types of these diseases. I am very much thankful to the postgraduates of the Department of Ophthalmology of the Vishwabharati Medical College for collecting nice photographs for this presentation. And basically, one thing to remember is this presentation is basically at a basic level, not at the specialist level. And I now request the chairpersons as well as the seniors and juniors who are giving this particular project to make to comment on this presentation and also to make any suggestions which I might have missed some of the association in this particular presentation, so that it will be helpful for all the viewers as well as to me. Thank you for your patient hearing.
Thank you, sir. That was very wonderful presentation and covering all from embryology to various ocular disorders. That was very wonderful, sir. And in that development of kidneys and eyes, the similarities and the common syndromes and all. So thank you very much, sir. I request Shivakumar, sir, to comment. And I request all the audience to write the questions in Q&A box so that Bharani Kumar, sir, will answer.
So at the outset, it's a wonderful presentation by Dr. Bharani Kumar Reddy, and he has covered everything very extensively and then brought a very good correlation between kidney and the eye. One thing that's very interesting is why Sir Richard Bright is called the father of clinical nephrology. His father is able to see beyond 190 years, 1836, and today is 2023. So this long he could see to bring a connection between eye and kidney. That's the greatness of those personalities. The other important thing is for the nephrologist, the type of diabetic nephropathy which is categorized into two, an ischemic type and then proteinuric type, is known only for the last probably 10-15 years. On the other hand, if you see the description of Dr. Bharani Kumar Reddy, the retina is showing the changes of ischemia as well as exudative lesions. So if we had really had a good eye to understand, I think we would have understood the second component, that is ischemic type of diabetic nephropathy, I think quite earlier. So overall, but it's a double whammy. That means when one suffers, the other also is suffering. And because of the inherent nature of the genetics, or probably their vascular status, and then genetic polymorphism, etc. But it's a very elucidative, informative lecture, and I thank Professor Bharani Kumar Reddy for the excellent presentation, and Sai Vani for the good conduct of the program and their support.
Thank you.
Thank you,
very
sir.
much. Thank you.
Chandramohan sir, your opinion.
Yeah, ma'am. We are retina specialists. We keep on seeing for diabetic retinopathy day in, day out. So there are some features in diabetic retinopathy which suggest us that patient might be having a nephropathy also. Barna Kumar sir, in his presentation itself, he has told lot of retinal exudation is one suspicion that a patient might be having a nephropathy in him. Apart from that, multiple cotton wool spots, large cotton wool spots in the retina, as well as macular ischemia, another condition which we have reported in 2004 in Indian Journal of Ophthalmology. So, if patient has got sudden decrease in vision, and when we examine patient's macula area is ischemic, means the microvasculature around the macula, the capillaries are damaged. Then we have checked the association with hypertension, uncontrolled diabetes, HbA1c levels, cardiac, lipids, and microalbuminuria. So we found an association, strong association between macular ischemia and microalbuminuria. So since we published that article, whenever we have a case with macular ischemia, we refer the patient for a nephrologist for screening for kidney damage also, because there is a strong association. So whenever we see large cotton wool spots, multiple cotton wool spots, severe retinal exudation, and macular ischemia, we refer the patient to a nephrologist for screening of nephropathy. Another indication is when we are doing fluorescein angiogram. This is one of the common investigation that we do to confirm the presence of proliferative diabetic retinopathy or anything. So when we do fluorescein angiogram, when the patient has got urea levels higher and albumin levels, creatinine levels are higher, we take an opinion of nephrologist to whether to proceed with the fluorescein angiogram or not. These are the two times we interact with the nephrologist. In the same way, nephrologists also refer the cases to us. Whenever they see early microalbuminuria, they ask the patient to screen for diabetic retinopathy. As Yokumar sir told, one is getting affected, the other is also getting affected. So either we see a damage in the retina, we ask them to get nephrologist clearance. And whenever a nephrologist sees that early microalbuminuria is there and early kidney damage is there, they refer us for retinal examination. And one question that commonly comes between nephrologist and retina specialist is whether to use anticoagulant or not. This question, a lot of diabetic patients come and ask, sir, you told there is a bleeding in the eye, I'm using aspirin, can I continue to use aspirin? There is a very long randomized control study, ETDRS study, which has clearly showed that if it is aspirin, I'm talking about only aspirin, if patient is on aspirin, he can continue using aspirin. Aspirin has got no role in bleeding in a case of proliferative diabetic retinopathy. But with higher anticoagulants, like that given subcutaneously when hemodialysis is done, you give higher anticoagulants. In such cases, if you are intervening for any procedure like a vitrectomy, a surgery, or anything, then you take an opinion of nephrologist before proceeding for a surgery. So that is one question that is commonly asked by patients, whether we can continue aspirin or not. Aspirin can be safely continued for any indication, despite having proliferative diabetic retinopathy. These are the few points that I want to highlight as far as retina and nephrology is concerned.
Chandramohan sir, I have one query.
Yeah.
We are giving anti-VEGF injections
Yes.
for proliferative diabetic retinopathy. How many patients had AKI at your knowledge for those patients? Anti-VEGF.
Kidney disease. Madam, we are for past 15 years we are giving anti-VEGFs. But we have not seen cases. I have not seen a case with acute kidney disease, madam. Following this, we have seen cases with stroke or cardiac events following anti-VEGF injections, but not an acute kidney disease.
Will you check routinely creatinine post-VEGF?
Yeah. And post-VEGF, we don't routinely check, ma'am. We ask for blood urea creatinine before giving an anti-VEGF as a routine thing for screening, but we have not checked post-VEGF. But this is an interesting question. There are some articles coming recently in past 2 years saying that there is a deleterious effect of this anti-VEGFs on kidney. But there are case reports only, not randomized control trials that are done. But this discussion is going around in retina circles also. That anti-VEGF, because we are giving multiple injections of anti-VEGF, that might cause some amount of kidney damage. So now we are using safer anti-VEGFs, madam, like more and more ocular anti-VEGFs, which are very specific to anti-VEGFs, which don't enter the systemic circulation. Previously, we used to use a molecule called bevacizumab, which is a pan anti-VEGF inhibitor, and which used to have a high concentration in the blood following intravitreal injection. But the anti-VEGFs which we use nowadays, they are very ocular specific anti-VEGF A only inhibitors, and also their systemic absorption or their systemic concentration following anti-VEGF injection is very less. But still, we have to be cautious, and we have to wait for further reports. Acute kidney disease we are not seeing, but a chronic effect of this anti-VEGFs we have to study.
Okay, sir. Thank you very much. Anil, sir. Anil Kumar, sir.
Anil is mute.
Yeah, good evening, madam. I think
Good
Bhavani
evening.
sir and Chandramohan sir have covered most of the issues. I have two questions to the nephrologist here. See, one is most of the CKD patients have anemia. And this anemia is worsening the diabetic retinopathy. So that aspect of anemia, sometimes we really don't know. We don't check into anemia regularly. But as general physicians and nephrologists, I think that anemia plays a very important role in worsening of diabetic retinopathy. So that has to be taken care of. The other thing is, of late, when dialysis patients come to us, many patients' blood pressure is little on the higher side. And when I spoke to one of the nephrologists, they have told that we keep it little on higher side so that the pore doesn't close. So what is the effect of that particular strata of hypertension which you are maintaining for that particular patient on the retina? So that I don't know. Chandramohan sir has to answer that. I have a doubt since long about that.
Yeah, definitely. When we are planning for a pan-retinal photocoagulation also, indication of pan-retinal photocoagulation is high-risk proliferative diabetic retinopathy. Whenever there is a high-risk proliferative bleeding, then we do pan-retinal photocoagulation. But in case of early nephropathy or little CKD patients, we contemplate doing pan-retinal photocoagulation early. In severe non-proliferative diabetic retinopathy to very severe non-proliferative diabetic retinopathy stage, we do a pan-retinal photocoagulation. This is because the patient's general condition is going to worsen, as you told. His hemoglobin levels are going to come down. He might become anemic, and more of exudation can develop at the later part of a kidney disease. So when we find a patient with an severe diabetic retinopathy and an early kidney disease, we do pan-retinal photocoagulation early. So that prevents some of the retinal complications at an early stage. But as you told, in a chronic kidney disease, when you see for the first time, you see a lot of hemorrhages, we see a lot of exudation. In such cases, it's difficult to manage proliferative diabetic retinopathy. So we need to treat the patient with anti-VEGF or intravitreal steroids, followed by pan-retinal photocoagulation in such cases.
Thank you, sir.
Thank you, madam. Our AP Society of Nephrology President, madam. Madam, please unmute yourself, madam. Madam, unmute yourself, madam. Unmute. Madam, not audible, madam.
Unmute, madam.
Can you hear me now?
Yes, madam. Yes.
Yeah. I congratulate Dr. Bharani Kumar Reddy for the extensive coverage of ocular manifestations in renal disease, starting from genetics to developmental to metabolic disorders to AKI and CKD and on dialysis and with other organ complications also. We had been, the as you have already mentioned, it involves not only the cornea, the anterior chamber, the lens, and then the posterior chamber and the retina. And particularly the retinal vessels, it is a window to the vascular system in the body itself. And as the vascular system is affected in the kidneys, definitely we would have a clue to it. As you had already mentioned that microalbuminuria, when you see, you have to send the patient to a ocular specialist, as well as when an ophthalmologist sees a patient with retinopathy, early retinopathy manifestations, it has to be referred to a nephrologist because all the organs need to be tackled at the same time. And there was a query put up by somebody saying the BP. Am I still audible?
Yes, madam.
Hello? Yeah. The ideal BP to maintain will be somewhere around 130 to 140 in the pre-dialysis or interdialytic period, so as to keep the AVF open. Sometimes if the BP falls to less than 120 or somewhere around 110, there is a likelihood of AVF closing. So this is the preferred BP we would like to keep somewhere around at least 120 to 140. And in most patients, somewhere around 130 to 140 would be required as a systolic BP to maintain in the interdialytic period. Okay. And thank you so much, Dr. Bharani Kumar Reddy, Dr. Shivakumar sir, Dr. Chandra Mohan, Dr. Anil, Dr. Saivani and Dr. Varun for conducting this meeting so beautifully. And thank you all.
Thank you,
There are few questions in the chat box, ma'am. First
Varun,
one is by
first do you have any queries?
No, ma'am. No, ma'am. Regarding chat box.
Okay.
Yeah. There actually one question from Dr. Shaktived, sir. He is asking about transplant recipients. The previous experience of cystoid macular edema in patients who undergone kidney transplant and who are on mTOR inhibitors, like rapamycin inhibitors.
Yes.
Chandra Mohan will answer.
Yes, sir. Yes. Sir, post-renal transplant, we have few issues, sir. One is, as asked in question was asked in chat box, the incidence of cystoid macular edema is more in them. And also when we are planning to give anti-VEGFs, also we have to be little careful. And another few things regarding our patients will be on immunosuppressions and steroids also. So the incidence of cataract is more. The incidence of diabetic retinopathy progression is more, and incidence of diabetic macular edema is more. So that is why patients with post-renal transplant need specific care by an ophthalmologist to check for all these: presence of cataract, presence of diabetic retinopathy, and presence of macular edema. And cataract is a safe procedure. Can be done in post-renal transplant patients also, because it doesn't need any systemic medication also. But when you are giving anti-VEGF, we have to be careful. We have to check whether the graft is recipient is stable or graft is stable. Then only we can give anti-VEGFs. In some cases where we prefer steroids over anti-VEGFs in these patients, because intravitreal steroids will not produce any systemic side effect either on the kidney of the patient. So we avoid anti-VEGFs in such conditions. And also we plan doing panretinal photocoagulation in the early stages of these disease in recipients, like very severe NPDR, even before they go to severe proliferative stage, we do laser in these cases. So doing laser early in these patients, avoiding anti-VEGFs as much as possible are the two important things that we have to keep in mind in post-renal transplant patients.
Thank you, sir. So I think the next question also to you only. Is the increased creatinine a contraindication to anti-VEGF?
No, sir. We have been doing anti-VEGFs in patients with high creatinines also, patients on dialysis, and patient post-renal transplant also. But post-renal transplant you usually avoid. In high creatinines, we do give anti-VEGFs, and it's not a contraindication. But majority of nephropathy patients, the edema is so severe that steroid is more effective when compared to anti-VEGFs. So we give more of intravitreal steroid when compared to anti-VEGFs in nephropathy patients.
Then one more question is about the concurrence between diabetic retinopathy and nephropathy. Is the severity of retinopathy, does it correlate with the severity of nephropathy?
Yes, sir. As I told, there
I
are
think
few
so.
there are few markers which say that patient might have nephropathy. One is cotton wool spots. Usually diabetic will have less cotton wool spots. Hypertensives will have more cotton wool spots. But cotton wool spots in nephropathy patients will be larger in size. Means the ischemia of retina will be more so larger in size. If you see more larger cotton wool spots, that is one indication. Macular ischemia is another indication that patient might have nephropathy. And lot of retinal hemorrhages and severe edema and exudation. These are the features if you see in a diabetic retinopathy that retina specialists usually think that this patient might be having a nephropathy, and we send them for nephropathy screening.
Thank you, sir. Sir, and one last question. Do you use OCT for cystoid macular edema regularly? And how do you monitor?
Yes, sir. Yes, sir. OCT is the indication of choice because when we, in a case of macular edema, when we do an OCT, if the center of the fovea is not involved with edema, then we can treat the patient with a laser treatment, I mean non-invasive thing. But once the center of the macula is involved with edema, then we have to go for either anti-VEGF or intravitreal steroid along with systemic control. So OCT is the investigation of choice, and we have to repeat it before the injection and 1 month after the injection to know whether the edema has come down or not. It is a non-invasive indication. Previously, we used to do more of angiograms. Now, almost the angiograms have come down, and we are doing more of OCTs in assessing the macular status in these patients.
Thank you, sir. Thank you for that. There are no more questions, ma'am.
Sir, Chandramohan, sir, how common is uremic optic neuropathy, sir? Because I have seen one case of uremic optic neuropathy and it's resolved very nicely after the patient was seen by the nephrologist.
Okay.
And we didn't even give steroids to that particular patient. But how
most common optic neuropathy what we see with nephropathy patients are anti-ischemic optic neuropathy. That is very common. Anti-ischemic optic neuropathy, wherein a sector of optic nerve gets ischemic or a total optic nerve become pale and edematous. That is the most common optic neuropathy that we see. And we do see uremic, but not so common, Anil. Most common is anti-ischemic optic neuropathy.
Will it improve after dialysis, sir, that uremic optic neuropathy?
Uremic optic neuropathy has got good response, madam, but ischemic optic neuropathy has got a little poor prognosis because whatever segment becomes ischemic may not recover. We have to see that the edema comes down and it doesn't spread into the rest of the optic nerve. So they will have sectoral scotomas even after resolution of ischemic optic neuropathy.
Shivakumar, sir.
So, two things I want to say. During our training days, our professors used to insist that before you introduce a patient onto maintenance dialysis, before you give a shot of heparin, make sure that their eyes do not have significant proliferative retinopathy in diabetics. So we all used to see the fundus on our own, and then if there is a need, we used to refer them to ophthalmologists prior to taking them onto dialysis, because we don't want to make them blind. But nowadays, as I see the postgraduates, most of them are not willing to carry ophthalmoscopes with them. So we have no right to spoil somebody else because we do not want to do something which has been done by all the predecessors in the earlier times. And it's a very protective thing. That's one. The second thing is there are studies dividing the entire retinal field into 4 quadrants, and then the measurement of exudative lesions and then correlating with proteinuria. Some of the studies have shown that there is a correlation between the severity of the kidney disease and then the severity of the retinal disease in diabetic patients. So these are the 2 things that I want to add.
Thank you, sir. Jikki, ma'am.
They have also covered post-transplant problems in ocular manifestations, and that's what was left out at that time. Anything more to comment, ma'am?
Okay. Bharani, sir.
First of all, thank you, madam, for allotting me this particular topic. Hope at least I have lived up to 50% of your expectations.
No, sir,
from
it
this
was very
presentation.
wonderful
It was
presentation.
very
When I heard about the talk, I was thinking what are the topics you are going
lucidly covered.
extensive talk, sir.
Thank you, sir. Thank you very much.
So if there are no questions, we'll
No more
end
questions.
the day. And this is the last presentation of this year from AP
The
Society
year.
of Nephrology. And I wish all the members of APSN and others very happy new year. And from next year, we will come up with new topic. And the Friday, we'll come up with new topic. Thank you. Thank you very much. Varun, is there
Yeah, I
any?
wish you the same.
Nothing.
And
Happy to all,
wish you
ma'am.
Thank you.
all a very happy new year too.
Thank you, ma'am. Happy New Year, everyone.
Happy New Year to all of you.
Thank you.
Thank you, sir. Thank
You
you.
all.
Thank you, sir. Thanks.
Thank you all.
Thank you, sir.
Thank you, sir. Thank you.
Happy New Year to everybody. Thank you, madam.
Thank you, sir.
Thank you, sir. Thank
Very
you.
nice talk, sir. Very nice, sir.
Well,